Hello everyone. Welcome to the fourth session for our MRCOG Part 2. I am Dr. Devyani, your mentor at Just MRCOG. Today we will be discussing a very important guideline regarding nausea and vomiting in pregnancy and hyperemesis gravidarum. We will be also referring to all the green top guideline highlights and then solve the questions accordingly. So let's begin. Yes, this is the Green Top Guideline, which has been updated recently in 2024, and it is the Green Top Guideline number 69. So the first question, what is the most appropriate intravenous solution for rehydration in women with nausea and vomiting of pregnancy? The options are A, 5% dextrose, B, Hartmann's solution, C, human albumin solution, D, normal saline 0.9% with potassium chloride, and E, normal saline 0.9%. I think we all know this answer is very easy. It is normal saline 0.9% with potassium chloride. That is option D. All right. Okay, so we'll see what the Green Top guideline says. Normal saline 0.9% sodium chloride with additional potassium chloride in each bag with administration guided by daily monitoring of electrolytes is the most appropriate intravenous hydration. And why is this done so, and what is the rationale behind it, is that most women admitted to hospital with hyperemesis gravidarum are hyponatremic, hypochloremic, and hypokalemic as well, and therefore it seems appropriate to use normal saline 0.9% sodium chloride and potassium chloride to rehydrate these women. All right, we'll move on to the next question. A 28-year-old in her third pregnancy presents with mild nausea and vomiting. She gives a history of hyperemesis gravidarum in her previous pregnancy. She is very anxious and worries that her condition may worsen similar to her previous pregnancy. What advice will you give her? A. Treatment with steroids if symptoms worsen. B. Treatment with domperidone if symptoms worsen. C. Treatment with cyclizine if symptoms worsen. D. Reassure that recurrence is unlikely in this case. And E. Admission to hospital and intravenous hydration with 0.9% normal saline. Okay, so put your answers in the chat box and we'll see what the answer is. The answer is treatment with cyclizine if the symptoms worsen. Let's see what the guideline says. Women who have experienced severe nausea and vomiting in pregnancy in a previous pregnancy may benefit from initiating dietary and lifestyle changes, such as arranging for childcare to facilitate rest and adjusting to a little and often diet and commencing antiemetics before or immediately at the start of symptoms in a subsequent pregnancy. Women who have experienced hyperemesis gravidarum in 2 or more pregnancies reported that earlier use of antiemetics was a factor in reducing the number of hospital admissions they had in the second pregnancy. Okay, so women who are coming with a history of hyperemesis in a previous pregnancy, they need to be preemptively started upon antiemetics. They should be offered antiemetics even before the symptoms appear so that it can be helpful in reducing the symptoms which may appear. Okay, so they should be offered regardless of whether they are started or not. This should be kept in mind in case they have a history. So a proper history taking is very important, and in case there is such, they should be started on the first line medications as soon as they present with any even mild symptoms. Okay, moving on. This is a EMQ now. A woman with severe nausea and occasional vomiting is at 10 weeks in her first pregnancy. How would you manage her? The options are ginger syrup, herbal tea, decaffeinated coffee, doxylamine with pyridoxine, yoga, ondansetron, vitamin B6 only, doxylamine only, steroids, proton pump inhibitors. Now, what do you think the answer is? She is presenting with hyperemesis at 10 weeks in her first pregnancy. So the first line medications and the second line as well as third line all should be known by us. We'll see what the answer is. Yes, I think all of you got it right as well. First line treatment is doxylamine with pyridoxine that starts at 20 milligram per oral at night. Okay, we should know this table, the first line, second line, and third line medications. First line medications include doxylamine and pyridoxine, which is to be given 20 milligram per orally at night. This can be increased to 10 milligrams in the afternoon and morning, both, if the symptoms don't subside. The other medications are cyclizine, prochlorperazine, promethazine, chlorpromazine. Second line includes MOD, that is metoclopramide, ondansetron, and domperidone. And third line includes the steroids. And you can read the line here, steroids should be reserved for the cases where standard therapies have failed. Okay, and when initiated, they should be prescribed in addition to previously started effective antiemetics. Okay, they should always be in addition, not as the sole treatment, right? And precautions, women who take corticosteroids should have their blood pressure monitored, and a screening for diabetes also has to be done, as they have impaired glucose tolerance when they have the sugar levels obviously deteriorate when you start them on corticosteroids. The next question now, the major mechanism of hyperemesis and nausea vomiting in pregnancy has been related to hypersensitivity to what? Right? The options are HCG hormone, thyroid hormone, growth differentiation factor 14, growth differentiation factor 15, and human placental lactogen. I think you all know this answer is GDF 15. We'll see the answer. Yes, so growth differentiation factor 15. The evidence says the major mechanism of nausea vomiting in pregnancy and hyperemesis gravidarum has recently been elucidated to be related to hypersensitivity to vomiting hormone growth differentiation factor 15, not 14, right? GDF 15 caused loss of appetite, taste aversion, nausea, vomiting, and weight loss. Variation in GDF15 gene, both in families and in unrelated individuals, is associated with hyperemesis gravidarum. All right, we'll move on to the next question now. Which of the following is not indicative of dehydration, that is hydration deficiency, and is not associated with the severity of nausea and vomiting of pregnancy? The options are A. Ketonuria, B. Abnormal liver function test, C. Abnormal kidney function test, D. High amylase, and E. Electrolyte imbalance. Okay, what is the answer? Let's check it out. Answer is ketonuria. The Green Top guideline says ketonuria is not an indicator of dehydration in pregnancy and should not be used to assess the severity. Okay, the other options, the investigations which can be done and should be done offered to the patient are urinalysis. Nitrites may indicate infection and needs to be ruled out. The presence or absence of ketonuria in pregnancy is not an indicator of dehydration. Assessing urinary ketones does not have a use in the management of nausea, vomiting in pregnancy or hyperemesis gravidarum and may be misleading. Urea and electrolytes needs to be done to guide intravenous fluid hydration as well as electrolyte replacement. The electrolytes, hypokalemia, hyperkalemia, full blood count, the blood glucose levels, ultrasound scans for the intrauterine pregnancy, and also the growth scans need to be done in case there is severe nausea vomiting in pregnancy which is not being relieved into the second trimester as well. LFTs also need to be done to exclude other liver diseases like hepatitis, gallstones, and also for monitoring malnutrition. All right. So this is the answer. Ketonuria is not an indicator of dehydration. Next question. A 26-year-old woman at 11 weeks in her second pregnancy presents with severe vomiting. Her investigations show increased free thyroxine and suppressed thyroid stimulating hormone. Her PUQE score is 9. What is the management? Right. So now the options are offer ginger syrup, commence her on the medications like propylthiouracil, treat her for hyperemesis in the community and not the abnormal thyroid function test, admission to the hospital for assessment and treatment, reassurance, repeat the thyroid function test, and termination of pregnancy. Okay, what do you think the answer is here? Her PUQE score is 9 and she has abnormal thyroid function tests. So will you treat her for that or will you treat her for the vomiting? We'll see what the answer is. Treat her for the hyperemesis in the community and do not treat the thyroid function test. Okay, the option is C, that is treat the hyperemesis in the community and not the abnormal thyroid function test. Why it is so? Let's see the answer. In two-thirds of women with hyperemesis, there may be abnormal thyroid function test based on structural similarity between thyroid stimulating hormone and HCG with the biochemical thyrotoxicosis and raised free thyroxine with or without a suppressed thyroid stimulating hormone level. These patients rarely have thyroid antibodies and are euthyroid clinically. The biochemical thyrotoxicosis resolves as the hyperemesis improves, and treatment with antithyroid drugs is unnecessary. A raised T4 and low TSH therefore do not need treatment in straightforward nausea and vomiting of pregnancy and hyperemesis gravidarum, where the cause is clear and patient is responding to treatment. So you do not need to treat her abnormal thyroid function test initially if it is a straightforward nausea and vomiting in pregnancy and there is no presence of the antibodies as well. If there is so that you suspect some antibodies to be present and there are symptoms of suggesting autoimmune condition, Graves' disease needs to be ruled out. But in a straightforward case, this does not indicate a abnormal thyroid function test and testing is not required. All right. And the PUQE score 3 to 12 with no complications requires management in the community. With antiemetic therapy, support, reassurance, encouraging oral hydration, and offering her dietary advice, considering the use of laxatives if required, prescribing histamine type 2 receptor blockers or the proton pump inhibitors if there is some evidence of gastroesophageal reflux disease, and mental health assessment is required with or without referral to the perinatal mental health services when required, as these women are at a risk of developing mental depression, post-traumatic stress disorder as well. All right. So this is the answer, option C. Moving on. A woman presents at 10 weeks in her first pregnancy with severe nausea and vomiting. She is unable to tolerate oral medications. Her thyroid function test results are as follows. The TSH is reduced to 0.1 and the free thyroxine is increased to 25 picomole per liter. Her PUQE score is 15. What is the management? Offer ginger syrup, commence her on antithyroid medications like propylthiouracil, treat her for hyperemesis in the community and not the abnormal thyroid function test, admission to the hospital for assessment and treatment, reassurance, or repeat the thyroid function test, and the last option is termination of pregnancy. Now here she is unable to tolerate oral medications. This is an important line. You need to know this is an indication for, let's see the answer, admission to the hospital for assessment and treatment, right? So this patient is having a PUC score of 15 but is unable to tolerate oral medications. Now let's see if there is a PUC score of more than equal to 13 with no complications. She is unable to tolerate any oral medications or in any intake as well orally, then community measures have failed. If any of these three, either of these three, you will refer her for ambulatory daycare. Now, in this patient, we saw that the statement, she is clinically dehydrated. She is unable to tolerate oral medications, right? You can see here any PUC score with complications, inability to tolerate oral intake, unresponsive to outpatient management, clinical dehydration, weight loss of more than 5%, confirmed or suspected comorbidities like any urinary tract infection, diabetes mellitus, comorbidity and unable to take medications, comorbidities like epilepsy, HIV, hypoadrenalism, psychiatric disorders, all these are indications for IPD management. So here our option is admission to hospital for assessment and treatment. As I have highlighted here, she is unable to tolerate oral medications, okay? Inability to tolerate oral medications, right? Moving on. A 19-year-old woman in her first pregnancy attends the emergency department with nausea and vomiting. She is 10 weeks into her pregnancy according to the last menstrual period. She is clinically dehydrated. Now, again, this statement is important, clinically dehydrated. Which of the following is true regarding the treatment of nausea and vomiting in pregnancy? A. Corticosteroids should be reserved for severe refractory cases where standard therapies have failed. Yes, we read this statement just now a while ago. Second is dextrose with additional KCl, that is potassium chloride in each bag, guided by daily monitoring of electrolytes is appropriate. Not dextrose, it is sodium chloride, that is 0.9% saline. Option C, first-line antiemetics such as antihistamines and phenothiazines are not proven to be safe. In fact, they are safe in pregnancy as the first-line medications. Option D, metoclopramide is safe and effective and can be used as a first-line therapy. No, it is a second-line therapy. Option E is pyridoxine is not recommended for nausea and vomiting in pregnancy. Pyridoxine is in fact recommended along with doxylamine. All right. So the option correct is C, is A, corticosteroids, right? As they are reserved for severe refractory cases. So option A is right. Corticosteroids should be reserved for severe or refractory cases with nausea vomiting as standard when standard therapies have failed. Let's see the guideline. The use of dextrose intravenous infusion for fluid replacement is not recommended. Why is it not recommended? Because it can precipitate Wernicke's encephalopathy in patients who have thiamine deficiency. What about corticosteroids? They should be reserved for cases where standard therapies have been ineffective and used in combination with antiemetics. All right. Then thiamine supplementation, either oral 100 milligram TDS or intravenous as a part of vitamin B complex, should be given to all women admitted with vomiting or severely reduced dietary intake, especially before administration of dextrose or any parenteral nutrition. All right, moving on to the next question. Question number 9. A 20-year-old woman is admitted with nausea and vomiting in pregnancy at 7 weeks of gestation. What signs will make you diagnose hyperemesis in this woman? So now you should know what the definition according to the RCOG guideline is. Let's see the options. A. Nausea, vomiting in pregnancy with 5% weight loss, electrolyte imbalance, and dehydration. B. Nausea, vomiting in pregnancy and 5% weight loss and electrolyte imbalance. C. Nausea, vomiting in pregnancy with weight loss of more than 5% pre-pregnancy weight, dehydration, and electrolyte imbalance. D. Severe nausea, vomiting in pregnancy beginning early in the pregnancy before 16 weeks, inability to eat and drink normally, and limiting activities. And last option is nausea, vomiting in pregnancy, 5% weight loss, electrolyte imbalance, and dehydration, along with abnormal liver function test. Let's see the answer. The correct answer is D, severe nausea, vomiting in pregnancy beginning early, that is before 16 weeks, inability to eat and drink normally, and limiting activities. Okay, so what are the recommendations according to RCOG guidelines? Hyperemesis can be diagnosed when symptoms start early in pregnancy. Nausea and vomiting are severe enough to cause an inability to eat and drink normally and strongly limits the daily activities of living. Signs of dehydration are contributory to diagnosis. So this is the answer. Let's move on to the next question. Which electrolyte imbalance is expected in cases of nausea, vomiting in pregnancy and hyperemesis to develop? A is hyponatremia, hypokalemia, low serum urea, raised hematocrit, and ketonuria. B is hyponatremia, hyperkalemia, high serum urea, raised hematocrit, and ketonuria. C is hyponatremia, hyperkalemia, high serum urea, low hematocrit, and ketonuria. D is hyponatremia, hyperkalemia, low serum urea, raised hematocrit, and ketonuria. And last option is metabolic acidosis. So we know in hyperemesis, everything falls low. That is all electrolytes, hyponatremia, hypokalemia. There is low serum urea as well, but the hematocrit raises because of the dehydration. So I think the option is A. Let's see the answer. Yes, the option is A, hyponatremia, hypokalemia, low serum urea, raised hematocrit, and ketonuria. Let's see the green tub guideline. Nausea, vomiting in pregnancy and hyperemesis gravidarum are associated with hyponatremia, hypokalemia, low serum urea, raised hematocrit, ketonuria with a metabolic hypochloremic alkalosis. Right now, if severe vomiting develops, the alkalosis changes to metabolic acidosis. This should be known. Okay, these are the metabolic abnormalities in hyperemesis. Next question. A 25-year-old woman is seen at 7 weeks of gestation in her first pregnancy with severe nausea and vomiting in pregnancy. She is clinically dehydrated. Initial management has failed to stem the vomiting. Further investigations have been performed, including a thyroid function test. These have been reported as increased free thyroxine and suppressed thyroid stimulating hormone. Her PUQE score is 7. What should be the recommended management of this biochemical abnormality? I have highlighted this clinically dehydrated, and we had seen that this is an indication for inpatient management. Let's see the options. Commence her on antithyroid medications. Commence her on carbimazole. C is commence her on propranolol. D is treat the hyperemesis in the community and not the abnormal thyroid function test. E is commence carbimazole and check the TSH receptor antibodies. F is commence propylthiouracil and repeat the thyroid function test in 6 weeks. G is ambulatory daycare and check TSH receptor antibodies. H, supportive treatment for nausea vomiting in pregnancy and repeat TFT in 6 weeks. I is admission to hospital for assessment and treatment. J is treatment with cyclizine and symptoms worsen. And the last option is treatment with ondansetron as the symptoms worsen. Right? Put your answers in the chat box. We'll see the answer. Right. Answer is I, admission to hospital for assessment and treatment. As we already saw, the criteria for inpatient management includes clinical dehydration, which is a admission criteria. And we do not need to treat her thyroid function test immediately. We will just treat her hyperemesis. And we saw that in 2/3 of the cases, it is only because of the hyperemesis that is the biochemical abnormality develops. And once it is treated, this thyrotoxicosis may resolve on its own. So the answer is admission to hospital for assessment and treatment. Next question. A 30-year-old woman at 9 weeks gestation presents with severe nausea and vomiting. Her symptoms subsided after giving her a combination of metoclopramide, promethazine, and prochlorperazine. She's stable now. How will you stop the treatment? Your options are A, continue all, B, stop cyclizine, C, stop metoclopramide and cyclizine, D, stop metoclopramide and continue other medications, E, stop metoclopramide and stop others gradually. What is the answer? Let's see the answer. Answer is stop metoclopramide and stop other medications gradually. Why is this so? The metoclopramide risk. Metoclopramide should be used as a second-line therapy and only for a short duration, that is maximum of 5 days, because of the risk of extrapyramidal side effects, particularly tardive dyskinesia, right? In clinical scenarios where the patient has stabilized, it is typically the first medication to be discontinued. Preventing relapse. For patients with severe nausea, vomiting in pregnancy or hyperemesis gravidarum, sudden suggestion of all the antiemetics often leads to a rapid relapse of symptoms. Clinical practice involves a step-down approach where medications are withdrawn one at a time and reduced gradually rather than stopped abruptly. Okay. And in case of combination therapy, when a patient is on multiple agents like prochlorperazine, promethazine, etc., the most prudent approach is to remove the highest risk medication first. In this case, it is metoclopramide, and then taper the remaining drugs gradually because there can be a relapse as well. Okay. So the answer is option E. Moving on to the next question now. Question 13. Patient is admitted for hyperemesis gravidarum and improving to treatment. Clinician should be aware of refeeding syndrome. How to recognize the syndrome? So now here you are being asked about refeeding syndrome. What is the sign what is the clinical abnormality in refeeding syndrome? Options are A, hypokalemia, B, hyponatremia, C, hypophosphatemia, D, hypochloremia, and E, hyperkalemia. Okay. So you all should remember this, that in refeeding syndrome, the hallmark sign is hypophosphatemia. What is refeeding syndrome? It can be defined as potentially fatal shifts in fluid and electrolytes that may occur in malnourished patients receiving artificial refeeding, that is parenteral nutrition, whether enterally or parentally. Okay, these shifts from hormonal and metabolic changes may cause serious clinical complications, and the hallmark biochemical feature of refeeding syndrome is hypophosphatemia. However, the syndrome is complex and may also feature abnormal sodium and fluid balance. Changes in glucose, protein, and fat metabolism, thiamine deficiency, hypokalemia, and hypomagnesemia may also occur. All right, but the hallmark is hypophosphatemia. Let's move on to the next question. Patient in first trimester presents with vomiting. She was on first-line antiemetics, chlorpromazine, but shows no improvement. What will you do next? Start on metoclopramide and ondansetron. B, start on steroids. C is add other first and second line medications. D is admit the patient. E is conservative management. Okay, so she has not improved on chlorpromazine. What will you do? Let's see the answer. Add other first or second line drugs. So see this highlighted red box, minimal or no improvement with the community management. What should be done? You should add second line and third line antiemetics. When uptitrating, adding the drugs as opposed to replacing them is preferred. Many women will require more than one antiemetic. Refer for inpatient management if there are any red flags. So, how should the uptitration of antiemetics be done? This is a very important condition to be known. Initially, they have to be given first line medications, but if there is no improvement with first line medications, you have to add on the other first line and second line medications instead of replacing it. Okay, use combination of drugs in women who do not respond to a single antiemetic. When uptitrating, add drugs as opposed to replacing them. All right, so this is the answer. Add other first and second line drugs. Next question. What treatment should be given in ambulatory daycare for correcting electrolytes? Options: A. Normal saline with potassium chloride, B. Emotional support, C. Antiemetics, D. Analgesia. We all know the answer. We just now saw normal saline with potassium chloride. That is option A. We also have seen the Green Top guideline. So moving on. A pregnant woman at 10 weeks of gestation with nausea and vomiting with a PUQE score of 12. She is on cyclizine but not improving. The options: in patient management, ambulatory daycare, management at home, management in community, or wait and watch. What is the answer? She's on cyclizine, not improving, and a PUQE score of 12. Let's see the answer. The answer is ambulatory daycare. Now here, the patient was already on cyclizine, that is the community measures have already failed. Okay, so what is the next option? Will be referring to the ambulatory daycare. So we should know the criteria for management in community, management in ambulatory daycare, as well as inpatient management in case of any red flags. All this is very important. Please go through this table once again. Okay. Okay, that was the last question. Now we'll see some important examples which should be remembered, right? So the definition for nausea, vomiting in pregnancy, it is diagnosed when onset is prior to 16 weeks of gestation and the other causes have been ruled out. So it is a straightforward nausea, vomiting in pregnancy starting before 16 weeks. What is hyperemesis? It can be diagnosed when symptoms start early in pregnancy and they are severe enough to cause an inability to eat and drink normally and strongly limit the daily activities of living. Signs of dehydration are contributed to the diagnosis. This is hyperemesis. Next, some important percentages. Nausea and vomiting affects 90% of women and hyperemesis affects 0.3 to 3.6% of the women. Nausea vomiting pregnancy starts between 4 to 7 weeks, peaks at 9 weeks, and resolves usually by 20 weeks in 90% of the women. And if it lasts more than that, then it is a risk factor for developing growth restriction, and serial growth scans should be done in those women. Okay. That should also be known. Then major mechanism for hyperemesis is hypersensitivity to GDF15, that is growth differentiation factor 15, and the HCG hormone. How to assess the severity? You have two tools, that is the PUQE score, that is pregnancy unique quantification of emesis, and the HELP, that is hyperemesis level prediction tools. VT prophylaxis is important in all these women who are admitted with a hyperemesis as they are at a risk of thrombosis. The score is 3. So while they are in the inpatient management, they should be given the VTE prophylaxis. Next is, yes, this is the PUQE score. We should know the score as well. What are the questions being asked? You should ask the woman regarding in the last 24 hours, for how long have you felt nauseated or sick to your stomach? In the last 24 hours, have you vomited or thrown up? And in the last 24 hours, how many times have you had retching or dry heaves without bringing anything up? The minimum score would be 1 plus 1 plus 1, that is 3, and the maximum would be 5 plus 5 plus 5, that is 15. So minimum score of 3, maximum score of 15 is seen in this PUQ score, and it is known as PUQ 24, okay, because the PUQ 24. Right, and the maximum score is 15. Why is it 24? Because it deals with the last 24 hours. All right. Now, the next scoring system is the HELP scoring system. This also, please go through it once so that you are aware about it. And then when should enteral parenteral nutrition be given to the patient? When all the other medical therapies have failed to sufficiently subside the symptoms, and the enteral tube feeding or parenteral tube feeding then should be commenced. A referral to gastroenterology and a MDT approach, that is the multidisciplinary approach, in parallel to other medications, ongoing medication should be considered. And avoiding iron should be done. Why? Because it can exacerbate the hyperemesis. So you should avoid the iron containing preparation if these exacerbate the symptoms, or consider alternative route of administering the iron if she is iron deficient and requires it. Okay. Women should also be questioned about their bowel habits and offered laxatives if constipated. Women should be offered treatment with proton pump inhibitors for gastroesophageal reflux disease. What about antenatal care? Women should only be discharged once appropriate antiemetic therapy has been tolerated, adequate oral nutrition and hydration has been tolerated, and management of concurrent conditions is completed. All right. Then what else we should need? See the highlighted part here. When to offer serial scans. Women with severe nausea, vomiting, or hyperemesis who have continued symptoms into the late second or third trimester should be offered serial growth scans because they are at a risk of growth restriction. Right? Moving on now, the biochemical abnormalities, we saw this: hyponatremia, hypokalemia, low serum urea, and raised hematocrit ketonuria, along with metabolic hypochloremic alkalosis. And if it is severe, it turns to metabolic acidosis. In two-thirds of the women, there are abnormal thyroid function tests, but they do not need to be treated initially. The biochemical thyroid toxicosis resolves as the hyperemesis improves. Okay, and patients mostly are clinically euthyroid. Raised T4 and low TSH, therefore, do not need treatment in straightforward nausea, vomiting of pregnancy, and hyperemesis, where the cause is clear and the patient is responding to treatment. Liver function tests are abnormal in up to 40% of women with hyperemesis, with the most likely abnormality being a rise in the transaminases. Bilirubin and amylase levels may be mildly elevated as well. Okay. And regarding ketonuria, it is not an indicator for dehydration and should not be associated with severity of nausea vomiting, and it is not a criteria to judge the severity. All right. Another important percentage, what is the risk of recurrence in future pregnancy? That is 15 to 81%. All right. And how many percentage of women will go for termination of pregnancy in case everything else fails? That is, even the parenteral and the enteral nutrition fails in these women, then 10% of women may opt for undergoing termination of pregnancy. All right. We went through this chart also. Please go through it once again. When should you do community management? When should we go for ambulatory daycare management? And what are the red flags in which IPD management or inpatient management should be done? Okay. The medications and some side effects. Metoclopramide has a risk of extrapyramidal side effects, especially that is tardive dyskinesia. It should therefore be given IV slowly over 3 minutes for a maximum duration of 5 days, and the maximum dose is 30 milligram over 24 hours or 0.5 milligram per kg over 24 hours, whichever is lower. The antidote in case of toxicity of metoclopramide is IV procyclidine. Ondansetron can cause orofacial cleft defects in the babies, and hence it is better to be avoided in the first trimester. Okay. Again, when to manage in the community, in the ambulatory daycare, and the red flags for IPD management. First line, second line, and the third line medications, very important to be known. And when, how should you uptitrate the medications, and when should you consider the thiamine supplementation and VT prophylaxis for all the IPD management. All this, please go through this chart once again, and also the admission criteria. Okay. The postpartum care, planning for future pregnancies, and signposting. So, what should be done in the postpartum care? They are at a risk of post-traumatic stress disorder. So, considering referral to the perinatal mental health services is very important, and preemptive use of doxylamine and pyridoxine can be done in future pregnancies in case they have a history of hyperemesis in a previous pregnancy. All right. The support groups, please just go through the names: Pregnancy Sickness Support Group, Her Foundation, the UK Teratology Information Service, and Best Use of Medicine Pregnancy. All these patients can be referred to in case they present with hyperemesis. These are the support groups who will provide them with guidance and counseling in case they are needed, as these patients are very much prone to mental health conditions and need a referral to perinatal mental health services as well, and that should be offered to them. All right. This is all regarding this guideline. I hope you found it useful. If you have any doubts, you can put it in the comment section, or you can also refer to our Telegram group and the WhatsApp as well. Thank you so much.